Thank you for the invitation. I'm Shawn Hervey Jumper, as he's mentioned, from UCSF. This is an interesting topic, and I really want to just thank the organizers for inviting me, and this has been a great discussion so far. I have no disclosures, and I've changed the order of my talk a little bit because Dr. Das gave a really nice summary in his radiation talk about brain metastasis and some of the surgical implications associated with brain metastasis. So I'm going to focus primarily on the other common intrinsic brain tumor, gliomas, and we'll break this up in terms of what's the initial workup, what are our goals of surgery, and understanding a little bit more about molecular subclassification in gliomas. How does a neurologic deficit or impairment actually impact outcome, which should therefore inform our surgical goals? And this afternoon in the breakout session, we'll talk about how we accomplish some of these goals using some techniques in the operating room. So I put this slide up, and again, any neurosurgeon in the room, this is going to be really common to see, right? But when you're talking about gliomas and brain cancer, there's one concept that doesn't necessarily come forward all the time. It's the fact that by definition, these tumors are functionally integrated entities. And by that I mean there's both an oncologic problem as well as a neurologic cognitive problem as well. To the person who's not used to staring at a brain tumor, it's tough to distinguish where the brain tumor ends and the normal brain begins, and vice versa. And that same is true even when you're talking about tumors with a nodular component to it. There's a blending in between where the neoplastic cells and the non-neoplastic cells overlap. And that concept has actually been really interesting to me, and really the driving process and thought and questioning in my lab, actually. But taking a step back with respect to what the non-neurosurgeon needs to know about brain tumor surgery, we'll just take a bit of a step back for a second and just highlight the fact that the most common type of malignant gliomas, really roughly 50% of all malignant CNS tumors, incidence roughly 3 in 100,000 people, so not super high, but a common cause of death. Average age of diagnosis is 65, and overall survival is still between 18 to 20 months, depending upon some other variables. The only known risk factor is really ionizing radiation, right? There are no known environmental exposures. We don't think cell phones and things like that cause these, but there are some genomic variants. But even with these variants, and again, this comes up in clinic all the time, the risk of an individual person getting a glioma, even with these variants, is still quite low, to the point where we don't screen individuals. So if we're talking about what the non-neurosurgeon needs to know, one of the first things we think about is how do these patients present, right? Patient comes to the office or to clinic or emergency room with a brain mass, and there are a number of imaging studies we use which have been really highlighted well, but we'll just kind of highlight one point, which is that not all contrast-enhancing masses are gliomas, right? Many of these look the same: glioblastoma, brain metastasis, demyelinating disease, TB infections. And so usually at this point, they put the slide in for residents typically, but what is this ring-enhancing tumor, ring-enhancing mass? Is it a tumor? Is it something else? That's where we talk about diffusion-weighted sequences and show that this is a brain abscess, right? And as was really highlighted well in some of these, in an earlier talk, there are a number of imaging modalities that we can use to try to distinguish between tumor and non-tumor, glioma and non-glioma. I'm going to take this example here of this individual that is roughly 78 years old, dysarthria for several weeks, and you see this irregularly enhancing, rim-enhancing lesion with a central necrotic component. There's flare around it, minimal diffusion, restriction of diffusion, and a slight increase in perfusion, and this turns out to be a glioblastoma. And even so, with minimally enhancing tumors, we can use the same thing. So imaging tools such as MR spectroscopy, MR perfusion are used every day to help us distinguish between what may and may not be a tumor, which helps us counsel our patients about optimal management. When you're talking about surgical disease, it's really important to think about this idea of function, right? We know that these tumors live within a rich neural network, and some areas of these networks are more prone to neurologic injury, meaning they're less forgiving of functional integration, or less forgiving of insult. And so we can track that using DTI tractography. Again, DTI tractography for the cortical spinal tract is really robust, well used, pipeline for that in many institutions. And actually, it's pretty much, depending upon where you are, can be plug and play, can push, and it helps the surgeon understand the trajectory of these pathways, of these fibers, and proximity of the fiber to the tumor, which are really important considerations. And so as we think about a new patient that comes in with a presumed glioma, we have to think about how we counsel these folks for surgery. Who gets surgery and who doesn't, and why? And factors that are included in this discussion include extent of tumor volume, the size, location, the patient's functional status, medical comorbidities, social support, what we think the molecular subclassification might be based on demographics of the patient. And so, and our goals of surgery, which classically have been the same across individuals, may not always be moving forward. And I want to highlight a couple of examples of that and why that may be important. So I'll come back to this slide at the end, but take, for example, the 70-year-old woman with a right hemisphere tumor. With a dominant hemisphere right-handed woman. This temporal tumor, what are our goals? Do we want to remove the entire flare region? Do we want to remove the contrast-enhancing part, the necrotic center? And what's going to be a survival benefit to her? And I would argue that the decision that we make as surgeons really should be in light of what we think may be important from molecular subclassification, right? In the neuro-oncology world, we're splitters instead of lumpers now, right? We've decided that, based on WHO 2016, that molecular subclassification has significant impact on prognosis. But as surgeons, that is only starting to creep into our decision-making, partially because we don't fully know upfront what the molecular subgroups are, but before the tissue diagnosis, but we have some inferences on it. And this idea that prognostication and survival may be different with respect to surgery for different patients of diverse subgroups we've been started to scratch the surface on this. And this is a Race Wire group published in early 2019 on this topic. And in follow-up, we actually took roughly 3 years to complete this, but we wanted to look back at the UCSF series in a large data set and try to understand the interactive effects of volumetric extended resection, not just across newly diagnosed gliomas, but stratified by molecular and oncologic factors. And then, with the help of a couple of postdocs and residents, enfold what outcome would look like if we think about neurologic compromise both at baseline and following our surgical resection. Again, to try to understand the relative benefit in each of these situations. So quickly, let's talk about the data set. We're talking about 20 years of data, so you have to go back and molecularly reclassify an enormous number of tumors, which took most of the time. And then stratify our patients, really mostly focusing on the post-tube era. And those with IDH status, which were known, which really, when you're talking about IDH status, turned into roughly 500 or 475 individuals. This is a layout of tumors, again, IDH mutant, IDH wild type, IDH unknown. And for the purposes of today, I'll talk about the entire cohort, Stoop era, and then IDH mutant. We won't go into the MGMT today for the purposes of time. But if you look at all patients, all individuals with a newly diagnosed glioblastoma, you see what we've known for many years, right? If you look at the log hazard ratio of glioblastoma mortality using a Cox proportional hazard model, there is a benefit of extended resection, but that benefit levels out quite a bit between roughly 40 and 80% extended resection. And then there's a sharp drop-off once you get past the 80%. Now, that's been shown before, not using extended resection as a continuous variable, but as a categorical variable that's taking all comers together. But we can use different models to think about this. So we decided to use a recursive partitioning statistical analysis method. It's just a multivariate analysis tool that creates decision trees. And in these decision trees, the whole point is that it should classify members of this population or patients into subpopulations with based on independent variables. And so we can talk about how these decision trees split up, and I want to take them one by one because they're actually a little confusing to look at in total. So if you look at our individuals, let's do this. Let's start here. So if you look at individuals that perform the worst, right, that survive, that have the worst survival, these are individuals, as you would suspect, that do not receive temozolomide and have an older age, right? Not a big surprise. If you look at individuals who perform the best, and this is a really interesting group, these are individuals who receive temozolomide and are either IDH mutated or IDH wild type, younger age, under the age of 65, with less non-enhancing tumor volume, meaning greater extended resection of not just the enhancing tumor, but the non-enhancing tumor as well. And then we can fill in the middle with our second to worst performing population, no temozolomide, younger age, and again, yes, temozolomide, IDH wild type, older age, regardless of extended resection of post-op enhancing and non-enhancing volume. And the interesting part about this, and I want to just show make one important point, in that if you split up and focus on this middle slide here, if you split up this group 4 group, because it involves both IDH wild type and IDH mutant patients, here you can see that in aqua, the light color, we have our temozolomide receiving IDH wild type, IDH mutant group. But then this other dark blue group are the individuals IDH wild type, younger age, with less non-enhancing post-op volume. And if you look at this line that goes down to roughly 3 years, that suggested to us that greater extended resection of the non-enhancing tumor volume in a younger patient under the age of 65 can make an IDH wild-type patient perform like an IDH mutant patient for roughly 2.5 to 3 years. So again, and then just rounding this out, then if you add in our IDH, just the IDH wild-type individuals, you have what you would expect. Again, poor performers don't receive temozolomide and have less extended resection, and best performers are, again, younger age, contrast-enhancing and non-enhancing tumor volume, and then you have the folks in the middle, so even in the IDH wild-type only group. And so we begin to see that the relative benefit of extended resection in putting a patient at risk really varies based on patient age and molecular subclassification, which is a factor that we should, as surgeons, bring into our decision making. Again, knowing that we don't know our molecular subtype up front, but you can have some clues when you think about this with respect to patient demographics. So the other part we really wanted to try to understand in this data is this fact that as surgeons, many times in our pursuit of offering maximum resection, we can do patients harm, right? How does a brain tumor impact an individual? Well, it's both by tumor integration into functional areas, surgical lesioning, and the results of our therapies, radiation and chemotherapy. And Miriam Rahman, a good friend of mine at Miami, and others have studied this quite a bit, and she's shown again, this I think Hopkins has done this, several others. They show that, again, a neurologic deficit can not nearly erase, but severely limit the survival benefit associated with extended resection. So giving a patient a long-lasting neurologic deficit is really a big problem. But the challenge with these studies is that it's really a very heterogeneous group, right? You have to assume that many individuals with a cognitive, language, or motor deficit don't receive chemotherapy at all. They receive no treatment after that. And so, we wanted to try to understand that. And so we basically took our RPA tool and then took out all the individuals who received no temozolomide and then plugged into that our baseline and post-op neurologic deficits, focusing on weakness, paralysis, cognition, vision, and aphasia. And you can see first and foremost that baseline neurologic deficits had, in a univariate analysis, had no impact on survival, on overall survival. Then, if you look at post-op neurologic deficits, you can see that, again, these are all individuals that received temozolomide. Your severe post-op neurologic deficit, and this is a small number of individuals in this cohort, was the most predictive of impaired of a worse survival, combined probably with post-op hemiplegia, but not hemiparesis. So weakness alone is probably not enough. And then the biggest important factor for me to try to understand the role of neurologic deficits in this process was to really then plug all of that neurologic deficit data back into the RPA, into the multivariate statistics tool. And you can see that there is actually no change. So to me, it lets me know that as a surgeon, as I'm thinking about and talking to patients, presenting symptoms, the way they present, the way they look initially is probably not as big of an impact on overall survival as we give it credit for. Again, this patient selection and the individual has to be able to get through surgery, but I gave it a lot. I maybe giving it more credit than I needed to. Post-op cognition and hemiplegia are probably important, but they're less important really than age. In certain patient populations, extended resection of enhancing and non-enhancing disease. And if you can get the person through chemo radiation so that they get treatment like everybody else, then there may also be a survival benefit. So to me, it kind of put into perspective as a surgeon where neurologic deficits fits in the hierarchy of treatment for our patients. So in the Stoop era, I think it's important to say that temozolomide-treated patients that are IDH wild type and over the age of 65, they benefit from reduction of enhancing tumor. IDH wild type temozolomide treated patients under the age of 65 benefit from both enhancing and non-enhancing tumor volume, with a median survival in the IDH mutant with a median survival similar to the IDH mutant group. And that actually has been treatment and practice changing for me. And patients faring worse are those who do not receive temozolomide and are over the age of 65. So this is kind of the decision tree, the JAMA Oncology this work comes out in JAMA Oncology in 2 weeks, and they thought our RPAs were a mess, so they made us put this in to try to make things a little bit cleaner, and they made us put this decision tree in. So if patients 65 or younger, maximum extended resection of enhancing, and when safe and feasible, non-enhancing tumor volume. And then for less than, if they're not under the age of 65, you're really talking about the surgical goal should be enhancing tumor only, supported by this data. So again, in our hands, when you're counseling patients and thinking about the risks of surgery to patients, there's a bit of a difference when I'm thinking about surgical goals for a 70-year-old and 50-year-old based on tumor location and what I want to accomplish in surgery. This talk really didn't permit me to kind of go into brain mapping strategies and things like that, but it's very important when we think about removing non-enhancing tumor volume to use all the tools that we can, and we'll discuss those a little bit this afternoon with respect to not hurting individuals and offering resulting in permanent neurologic deficits. But that's what I wanted to share with you guys. I really thank you for the opportunity to speak. This has really been a great honor, and I'll answer any questions next.
That was a really helpful talk. I have a question about one slide. I don't think I really understood, but it was the one where you have a curve that is flat in the middle. It's probably about 25 slides back. Sorry, but
flat in the middle.
And then it goes down to 100% at the end. It was just.
Yeah. This is just
And could you?
Yeah. So this is just all comers, right? This is all 850 individuals. No subclassification of any sort. So this is just your log hazard ratio of mortality, right, based on extent of resection as a continuous variable. So this is a volumetric extent of resection. This is your hazard ratio. So, and again, the take-home point for me is it's actually relatively flat. This is where I think Ray Sawaya and some others suggested that there isn't much of a survival benefit unless you're going to get an extended resection of greater than 80%. And that's why I think that's why they captured that when they used it as a continuous, when they analyze their data as a continuous variable, because you can see that the line doesn't drop off until you hit just about 80%.
That's what I thought the take home was. And there are so many tumors where you have motor and speech areas nearby. So, and you think, well, let me see if I get like 60% versus 40%, whatever, maybe that'll help a little more, but that data is important that if you can't get it all out, then maybe you should not worry about getting 80% versus 50%.
Correct. And we have to argue that that may vary by age and what you think their subclass may be. Yeah, that's exactly. We tried to put this sort of analysis into the subclassification data, which just got really confusing really fast. Yeah.
So that case where you're comparing two age people on the hemisphere tumor, I'd have been more comfortable making that distinction of who's in the right temporal lobe.
Yeah.
On this side, it's complicated by the risk of language trouble.
That's why I put it that way, right? Because that's why I put that exact slide up. That's exactly right. Yeah, because it's a trickier situation, right? It's a relatively easy discussion if it's right-sided.
So let's say it was right-sided.
Mm-hmm.
In the younger patient, we go for a very lesion. And if I'm understanding the conclusions correctly, in the older patient, you just do a lesion.
So it's all again, what's not illustrated in these slides is how much of this is a discussion with the patient, right? What's their interest? What's their underlying medical comorbidities? What's their willingness to recover? But if all things are equal, I see very little benefit in removing flare disease in a 70-year-old within the dominant hemisphere. That's right, or any location, for sure.
If she was in right hand, you would want to go more aggressive in this location?
You have to map. You have to map and see, right? That's all about, so in a 70-year-old, you may consider not even doing mapping there, right? Because you're going to stay within the confines of the dead necrotic stuff. And a 50-year-old, you're talking about mapping. So you're never going to intentionally cause a deficit. But in talking to the patient, then you can quantify what is that relative benefit to them, or try to. Again, knowing that you're never going to intentionally remove eloquent tissues, right? That's just not going to happen. It's a bad idea.
Thank you.
You're welcome.